My name is Dave Loftus, and today we're going to talk about congestive heart failure. The learning objectives for today's talk are to understand the mechanisms of heart failure, to recognize the basic types of heart failure, to recognize the signs and symptoms of heart failure, and to understand the key treatments of heart failure. We will begin our talk with the classifications of heart failure. We will focus mostly on systolic heart failure, subtypes, and treatments. We will finish briefly with a talk on diastolic heart failure and right heart failure. First, what is heart failure? The job of the heart is to pump blood throughout the body in order to deliver oxygen and nutrients to tissues and support the metabolic activities of the body. When the heart fails to perform this duty effectively, a patient is said to have heart failure. Heart failure is a general term, and there are many different mechanisms that can cause the heart to pump inadequately. The easiest mechanism to think of is when the heart physically cannot squeeze or contract as hard as it should, and hence cannot pump as much blood out to the body. Alternatively, the heart's squeezing ability may be fine, but it cannot relax very well, and thus blood cannot enter the heart as efficiently. Relaxation of the heart is actually a very active process, not a passive one. So if the heart is very stiff or hypertrophied, it is more difficult for the muscles to relax, and diastolic filling of the heart is compromised. Obviously, if less blood fills the heart, then there is less blood for the heart to pump out to the rest of the body. Sometimes both the heart's ability to squeeze and relax are okay, but there are other conditions which prevent it from delivering blood effectively to the body. For instance, if the heart valves are very stiff or leaky, then the heart may be pumping blood okay, just in the wrong direction, such as backwards into the lungs instead of forwards to the rest of the body, which would happen with severe mitral regurgitation. There are many different causes of heart failure, and some of the more common ones are listed on this slide. By far, ischemia is the most common cause of heart failure. If a patient has a myocardial infarction or heart attack, then some of their heart muscle, myocardium, will die, so it makes sense that the heart would not be able to squeeze as well. As discussed previously, problems with heart valves, particularly aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation, can also impair heart function. When a valve problem occurs acutely, such as severe mitral regurgitation during a myocardial infarction, this can lead to acute heart failure. However, more commonly, patients have chronic problems with their valves, leading to either dilation or hypertrophy of their heart chambers, and ultimately progressing to heart failure. Patients with chronic, uncontrolled hypertension will often develop thickened or hypertrophied heart muscle, which makes the heart stiff so it cannot fill the blood as easily. Think of a bodybuilder whose muscles get big because they lift heavy weights. That's how the heart reacts to long-standing hypertension. Infiltrative processes such as amyloidosis, sarcoidosis, and hemochromatosis can also impair the myocardium's ability to both relax and squeeze. Patients with uncorrected congenital lesions, such as atrial septal defects, ventricular septal defects, and patent ductus arteriosus, can also lead to right heart volume overload and eventually heart failure over time. Various other causes of heart failure include infections, such as myocarditis from Coxsackie virus, Chagas disease, genetic disorders such as glycogen storage disease, Pompe disease, for example, alcohol, which causes a dilated cardiomyopathy, and various drugs, both prescribed and illicit. Cocaine is a common cause of cardiomyopathy in drug abusers. Chemotherapeutic agents such as doxorubicin or other anthracyclines are also common causes of heart failure. It is important to take a minute and discuss the functional classes of heart failure, since you'll hear much of these during your time as a physician. Heart failure is not a single disease, but a spectrum of disease. There are some patients with heart failure who are able to walk around and live very normal lives, and you'd never know they had heart failure. There are others with very severe heart failure that may feel terrible even when doing nothing. The New York Heart Association, or NYHA, functional classes of heart failure, describe the symptoms that patients experience and correlate with the severity of their disease. Patients with New York Heart Association Class 1 heart failure have little to no symptoms, even with significant exertion. Class 2 patients may experience symptoms only after significant exertion, such as shortness of breath after climbing several flights of stairs. Class 3 patients have frequent symptoms, even with minimal exertion, such as walking less than 1 block on a flat surface. However, they do not have symptoms at rest. Class 4 patients, on the other hand, represent the most severe disease, and these patients have symptoms with both trivial exertion, such as walking 10 feet across a room, and often at rest as well. To make it more confusing, there are several different ways that you can classify or categorize heart failure. Some people like to think of systolic heart failure versus diastolic heart failure, with diastolic heart failure being more commonly known as heart failure with preserved ejection fraction. Generally, an ejection fraction of less than 45% is used to define systolic heart failure. Remember that ejection fraction equals stroke volume divided by end diastolic volume. Think of this as the percent of volume that a full ventricle can pump out with one beat. A normal ejection fraction is 55% or more. Therefore, if the ventricle fills with 100 milliliters of blood, for example, then a normal ejection fraction would mean that it would pump out 55 milliliters of that blood, at least. Another way to classify heart failure is to distinguish left heart failure from right heart failure. Still another way is to distinguish ischemic from non-ischemic etiologies of heart failure. These terms can be somewhat confusing, and many of these categories can overlap. However, the most classic type of heart failure, and the type we'll focus on today, is systolic left-sided heart failure. As mentioned previously, ischemia is the most common cause of heart failure. Therefore, the patient you should be thinking of is someone who has a myocardial infarction in the past, and because of the area of dead myocardium, their left heart does not squeeze as well as it should. For the next several slides, we're going to focus on systolic heart failure. Remember, we're talking about the patient who's had a myocardial infarction and now has left heart systolic failure. These heart failure patients can present in a variety of states, either compensated or decompensated, or somewhere in between. I like to think of these patients in a clinical sense, and the two most important things to consider are their volume status and whether or not they're adequately perfusing their tissues. A person with normal volume status and good perfusion of their extremities will be considered warm and dry, meaning their extremities feel warm because blood is being pumped adequately throughout their body, and they are not volume overloaded, meaning that their lungs are dry and they do not have much edema. Patients with good perfusion, but who are volume overloaded, are considered warm and wet. Patients whose heart does not pump well enough to deliver sufficient blood to their extremities will feel cool or cold to the touch, since there is not as much blood being pumped to their extremities, and their blood vessels will try to constrict to maintain their blood pressure. Depending on their volume status, these patients will either be cold and dry or cold and wet. The table on this slide shows the different categories and is a good way for you to think of these patients when you see them on the wards. We'll take a closer look at each of these different scenarios in the next several slides. Warm and dry patients have normal volume status and good perfusion of their extremities. This is how a normal person would be if they didn't have heart failure. Even though these patients' ejection fraction is lower than normal, they have compensated heart failure, and they do not have any signs or symptoms of active heart failure. Since their volume status is normal, their lungs are dry, meaning there are no crackles, and they often don't have any peripheral edema. There are several therapies that are considered standard of care for the chronic treatment of these heart failure patients. These include ACE inhibitors, which not only help with blood pressure and reduce afterload, but help prevent some deleterious cardiac remodeling that can take place in chronic heart failure. Beta blockers have been shown to have mortality benefit for heart failure patients as well. This seems somewhat counterintuitive since these medications cause the heart to squeeze less strongly. In fact, several decades ago, chronic heart failure patients were given inotrope medicines to make the heart squeeze harder, but this actually led to worse outcomes. However, beta blockers have been consistently shown to improve outcomes, especially beta blockers such as carvedilol and long-acting metoprolol, known as metoprolol succinate. Diuretics such as furosemide are also important medicines for preventing volume overload and managing volume status. For patients with New York Heart Association Class 3 or Class 4 heart failure, aldosterone antagonists such as spironolactone or eplerenone have also been shown to significantly improve clinical outcomes. The benefit of aldosterone antagonists has also been shown in some New York Heart Association Class 2 patients, and their use will likely continue to expand in the future. ICD, or implantable cardioverter defibrillators, also have a mortality benefit for patients with severely reduced ejection fraction less than 35%. Studies have shown that patients with lower ejection fractions are more likely to have life-threatening cardiac arrhythmias, so an ICD can be placed to shock patients out of these potentially fatal rhythms if they should occur. Warm and wet patients are perfusing well, but they are volume overloaded. This is the typical heart failure exacerbation patient who comes into the hospital with weight gain, shortness of breath, increased peripheral edema, orthopnea, which is shortness of breath when laying down, and sometimes paroxysmal nocturnal dyspnea, or PND, which is waking up from sleep with the sensation that you can't breathe, classically described as patients rushing to the window and gasping for air. These patients often get this way by being non-compliant with their diets, such as eating too much sodium or drinking too much water. They may also have neglected to take their medications, particularly their diuretics such as furosemide. The patients will have pulmonary edema with crackles on auscultation. Chest X-ray will show engorged pulmonary vessels, many times pleural effusions, and fluid in interstitial spaces. Curly B lines are classic findings of pulmonary edema on chest X-ray, shown as straight horizontal lines extending inward from the periphery of the lungs. Jugular venous pressure, or JVP, is one of the best estimates of a patient's volume status, and these warm and wet patients will have elevated JVP. The top picture in this slide shows distended neck veins, which are actually the external jugular vein in this patient. Internal jugular veins are more difficult to visualize, but are a better estimate of volume status than external jugular veins. These patients may also have a third heart sound, or S3. This extra heart sound is heard shortly after S2, and is thought to represent the sound of blood entering the ventricle from the atrium, but sloshing against excess blood that remained in the ventricle and was not pumped out during the previous systole, since the patient and the heart is volume overloaded and cannot pump as effectively. In general, these patients can be treated with a regimen of LMNOP. The L stands for Lasix, or furosemide, to diurese the excess fluid off. M is for morphine, which may help some patients breathe more comfortably and can actually dilate some of the pulmonary vessels to help relieve some of the congestion in the lungs. N stands for nitrates, such as nitroglycerin, which causes primary venous dilation and decreases preload of the heart, which helps reduce the volume of blood that the heart is forced to pump against. O is for oxygen, used for patients who are hypoxic. If patients are severely hypoxic, then positive pressure ventilation, such as BiPAP, has been shown to be effective. And finally, P is for position, since these patients are more comfortable with their head upright, so the head of the bed should be at least 30 degrees upward. The next class of heart failure patients are the cold and dry patients. These patients are not perfusing well, but their volume status is either low, meaning they're dehydrated, or possibly their volume status is normal. Some of these patients may have been over-diuresed, so there's not enough blood volume to pump throughout the body. Alternatively, their heart may be pumping even worse than normal, but not bad enough to cause volume overload. These patients will have extremities that are cool to the touch. However, they will have dry lungs, no crackles, normal JVP, and little to no peripheral edema. They may or may not have an S3. Because their perfusion is decreased to the rest of their body, they may have decreased urine output and evidence of pre-renal renal insufficiency on labs. Since these patients need to have their heart squeezed more strongly, they will often need an inotrope such as dobutamine. Beta blockers should be discontinued until they are stabilized back to their baseline. If a patient is significantly dehydrated, then giving some extra fluids may actually help their cardiac function as well. The cold and wet category is the sickest of the heart failure states and the worst form of decompensated heart failure. Not only are these patients volume overloaded, but they are not perfusing well. This may be due to a sudden decrease in their ejection fraction, perhaps a new ischemic event or myocardial infarction, or sometimes just severe volume overload that overwhelms the heart. These patients have cool extremities, crackles in their lungs, elevated JVP, increased peripheral edema, and an S3. Many of these patients may require treatment in an intensive care unit. These cold and wet patients need both inotropes to make their heart squeeze more strongly, as well as diuretics to remove excess volume. In general, it is best to warm them up with the inotropes, such as dobutamine or milrinone, and then after that, dry them out with diuretics. Hence you'll hear the phrase, warm them up, then dry them out. Beta blockers, of course, should be held until the patient improves or stabilizes back to baseline. Our discussion has focused mostly on left heart systolic heart failure, since this is the most classic type of heart failure. However, I just want to mention some of the other forms of heart failure as well. Diastolic heart failure, also known as heart failure with preserved ejection fraction, or HFpEF, often occurs in patients with stiff hearts that cannot relax well. These are patients with chronic, poorly controlled hypertension that has led to hypertrophy of their ventricles. Patients with infiltrative cardiomyopathies, such as amyloid or sarcoid, may also have stiff ventricles. While patients in diastolic heart failure have hearts that still squeeze well, It is more difficult for blood to enter the heart because the thickened, stiff ventricles cannot relax appropriately. An S4 extra heart sound, which occurs just before S1, can often be heard. Diastolic heart failure is probably more common than people realize, but it is underdiagnosed. At times it can be more difficult to treat than systolic heart failure, but the therapies are generally the same. ACE inhibitors, beta blockers, diuretics, close blood pressure control is very important in these patients as well. Right heart failure can be due to many causes, but the most frequent cause is actually left heart failure. With chronic left heart failure, this causes chronic elevation in pulmonary pressures, which causes the right heart to work harder against higher pressures. Pulmonary diseases such as COPD or pulmonary hypertension can also lead to right heart failure. Uncorrected congenital lesions with left to right shunts will also eventually cause the right heart to fail. The right ventricle is generally weaker than the left ventricle, so it cannot handle these elevated pressures very well, and ultimately progresses to cor pulmonale, which is the most severe state of right heart failure. The key to right heart failure and its diagnosis is that these patients will present with elevated JVP and peripheral edema, but their lungs will be dry, no crackles. Control of volume status, as well as treatment of the underlying condition, are keys to treating right heart failure. In summary, heart failure is a spectrum of disease. Our talk is focused mostly on the left-sided systolic heart failure model, which is the most classic type of heart failure. Treatment of heart failure depends on the type of heart failure and the acuity of disease. There are many advanced therapies that continue to expand, such as heart transplantation and ventricular assist device, which we have not gotten into today. However, if you remember the basics from our talk, this should do you well in your career. Key references: